So the next part of our symposium is actually going to be presentations from MPG members. These are all people, some kinds of research grants over the last year from the division to do some of their research projects. So our first presenter is Kevin Ha. Kevin is a resident in lab medicine and pathology, and he's been working with Andy Nelson, and he's going to be presenting on the work he did in sinonasal teratocarcinoma.
All right, good afternoon, everybody. As Bharat mentioned, I am Kevin. I trained here as a pathology resident, and I'm currently a blood bank and transfusion medicine fellow. And I'm here today to talk about one of the projects that I'm doing with Dr. Nelson. I have no financial disclosures aside from the funding provided by the department. So some of the objectives of my talk is to go over, what exactly is sinonasal teratocarcinosarcoma, go over, what is known, what is, potentially the clinical significance of this, and then some of the findings from our study itself. So sinonasal teratocarcinosarcoma, SNTCS, which isn't even any shorter to say than the full thing. So it's a rare aggressive neoplasm that's mainly localized in the sinonasal region. And this term was first coined back in 1984 by some researchers, including Hefner, who worked for the American AFIP, Armed Forces Institute of Pathology, where they searched through essentially their database and found, males between the age of 18 to roughly 65 years of age. And they found roughly 20 cases and noted, this specific rare entity that had these features of, a carcinoma, a sarcoma, and had some teratoid features as well that were limited to the sinonasal region. So this is one of the entities where the nomenclature actually kind of makes sense. So there hasn't really been much published since that initial, coining of the term in 1984. A PubMed search for various terms that are related to this entity yielded roughly, less than 60 publications, and the majority of those were single case reports. However, most of those case reports noted a high rate of recurrence and mortality. So one of the papers that, kind of did a meta-analysis of this entity was published in 2014. In it, they noted that there was kind of a wide range of, involved patients, ranging from 0.1 years to 85 years, which is, not entirely helpful, but the average year is roughly, 54 years old. There did seem to be a noted male predominance, the ratio of roughly 7:1, suggesting, potentially there could be some relation to gender, but, the exact determination of that is unknown at this time. And as I mentioned, this entity typically occurs within the, sinonasal region, most commonly in the paranasal sinuses, and patients may present with complaints of nasal obstruction. They may have some nosebleeds, headaches, or other visual changes reported. As I mentioned, this is a very aggressive neoplasm, so this tumor can spread, and especially if it spreads intracranially, can lead to destruction of parts of the central nervous system, which can have serious adverse outcomes. So in terms of how this is diagnosed by pathology, so some of the morphologic features include the identification of a epithelial component as well as a mesenchymal component, both of them with malignant features, so a carcinoma and a sarcoma. One of the most well-reported features was a fetal type clear cell squamous type epithelium. And additionally, in terms of the mesenchymal component, you could see, potentially bone formation, chondroid formation, or also some, neural epithelial type rosettes or things like that. In terms of their staining pattern by immunohistochemistry, there wasn't really any specific markers that you could say that if this stain is positive, then this is definitely a sinonasal teratocarcinosarcoma. Rather, these different components stain for essentially an epithelial marker or a mesenchymal marker such as vimentin. So in terms of how this is commonly treated, the most commonly reported management was radiation therapy, surgical resection, and some cases had chemotherapy and some did not. And the most common surgical approach was reported to be an anterior craniofacial resection. And the most common type of chemotherapy used was cisplatin. In the majority of these patients, they noted a recurrence rate of roughly between 22 to 37%. And in those patients who did not receive chemotherapy, there was roughly about a 10% metastasis rate. And additionally, they noted that generally speaking, the average survival time was less than 2 years. So that brings us to the project, which, as I mentioned, is done in collaboration with Dr. Andy Nelson and also with Dr. Hector Mesa at the VA with generous funding provided by the department. So what are the goals of this project? So specifically, we were trying to address whether this entity is has a somatic cell origin or of a germ cell origin. And part of the ways that we were trying to get at that would be looking at isochromosome 12p, and this specific change has been noted in many neoplasms of germ cell origin, and it hasn't, as I mentioned, there aren't a lot of publications on sinonasal teratocarcinosarcoma, but there haven't been any negative reports saying this feature is not identified in this entity. So in going through this project, trying to get at whether this feature is present or not, that was essentially one of our goals. Additionally, going the immunohistochemical route, staining for OCT4, which has been noted to be positive in numerous germ cell tumors, and additionally it has been reported to be positive in NSCLC. So the idea being that if we can have definitively negative stains and definitively negative chromosomal findings, then this would lean more likely towards a non-germ cell origin. Additionally, one of the other goals of this project would be to identify any potential genomic alterations that could potentially be targeted by any specific therapies or inform any, how this neoplasm essentially develops and propagates. So, as I mentioned, this is a very rare entity. So I first encountered this, diagnosis over at the VA, and we decided to look up, how many more patients we could find in the various healthcare systems in this area. So we managed to find a total of 4 patients, 2 of them at the university and 2 of them at the VA. When we collected the formalin-fixed paraffin-embedded specimens that we retained in order to do, our potential analysis on, we evaluated it for its, acceptability in terms of what we were trying to do. And one of the university patients, they had one resection specimen with 2 parts from different sites, and we felt that, with these 2 sites, it could get at potentially the answer of tumor heterogeneity. In terms of the second university patient, unfortunately, the majority of the specimens that contained this neoplasm were decaled, and thus, we were unable to do our studies on that. In terms of the VA patients, each of the VA patients had, at least 2 distinct accession specimens that contained sufficient sample for our analysis. Thus, it serves as kind of a temporal analysis to see if there are changes that can be seen over time or not. So with the valid specimens that we were able to get, we proceeded to obtain unstained slides and curls for both the immunohistochemical staining as well as analysis by NGS. So we were, essentially limited on what we could do. Preferentially maybe doing like a whole genome or something more substantial than that would have been optimal. But in terms of what we were able to achieve, we used the Illumina TruSight 170 platform, which essentially allows us to use the FFPE, formalin-fixed paraffin-embedded material, to extract our material and analyze it on the same platform for both DNA and RNA changes. And there is, roughly, as you can see in the picture here, those are some of the genes that they included in their panel that are commonly involved in many neoplasms. And in terms of what we were looking at, some of these included genes were found on chromosome 12p, which we thought could serve as a surrogate marker for potential for the isochromosome 12p or any changes involved in that route. So in terms of the steps in this project, we did some, we prepped our specimens and did sequencing here in the department, and once all that numerous amount of data was outputted, we output that to the Illumina BaseSpace, which is a cloud-based analysis platform that both hosts the data as well as providing some kind of filtering and preliminary calling of some of the copy number variants, potential fusions, and single nucleotide variants as well. So in terms of the copy number variants and the fusions, we initially went with the pre-configured quality filters to try to get the data down to a level where it's humanly interpretable. In terms of the single nucleotide variants, we also use some quality filters and additionally use W-ANOVAR to further get at some of the annotations to some of the variants that are called. And we progressively proceeded to filter that further by excluding non-coding alterations and variants that had an allelic frequency of greater than 0.01 by the NOMAD database. And additionally, we used the VARSIM online resource to further classify and look at some of these variants and their potential significance. So in terms of some of our initial results, in terms of the stains that we did for OCT4, all the patients on all the specimens that we sent for IHC testing were negative for OCT4. In terms of the sequencing results, we identified roughly 6 to 8 potential single nucleotide variants of possible significance within each patient, and comparing between the samples within each patient, there was roughly about 95% concordance. And in terms of the copy number variants, roughly 2 to 13 CNVs per patient. These CNVs had a lower level of concordance, so that could be a question as to whether there's issues with the sample quality itself, or whether some of the threshold values we're using to filter and analyze this, it needs to be looked at a little bit more. In terms of some of the fusions, no fusions were identified by our platform and analysis. So going more specifically within to each patient, so for our university patient who had one accession specimen but two distinct sites, it was noted to have 6 concordant mutations between these 2 sites. Some of these included the FANCI, which included both a frame shift and a missense mutation. The frame shift is categorized as likely pathogenic, whereas the missense mutation is categorized more as a variant of uncertain significance. Additionally, MRE11, TP53, and FGF2 and FGF5 were also seen. These were, called, but their pathogenic significance is, kind of questionable. In terms of the one discordant mutation that was identified, One of the specimens contained a TSC2 deletion, which could indicate some level of splicing. If you can see by, by what we have here, we have this region that is completely deleted in one of the specimens, whereas it is present in the initial specimen, which could suggest potential heterogeneity in terms of the tumor or some other possible cause. In terms of the copy number variants, there is a deletion in BRCA1 as well as a duplication in CCND3. Now, these are a lot of, I guess, acronyms or words, and what do they exactly mean? So, in terms of some of the potential impact of these changes, in terms of the BRCA FANC-I pathway, so the FANC-I gene is part of a core complex that is involved upstream in terms of a FANC-D2 activation. And additionally, the BRCA1 is well documented as being involved in DNA repair, specifically with double-stranded break repair. So the idea is that the mutations in both the FANC-I as well as the BRCA2 could potentially suggest a kind of double hit change in terms of DNA repair, potentially leading to unregulated DNA changes. Additionally, MRE11 is a nuclear protein that is additionally involved in homologous recombination, telomeric length maintenance, and as well as double-stranded DNA break repair. So these changes are potentially interrelated and could suggest some loss of ability to repair any adverse changes. In terms of what was found in one of the VA patients, there was noted to be 6 concordant single nucleotide variants. They include ERB4, 2 changes in TET2, a frameshift and a missense change, as well as the MRE11. Additionally, the TSC2 change was noted, and one thing that was interesting was a single nucleotide change in the androgenic receptor was noted. This is classified as potentially clinically significant, but this specific feature is significant in patients who have androgen insensitivity, which to our knowledge none of our patients had that clinical diagnosis. In terms of some of the copy number variant changes identified, FGFR3 duplication was identified, as well as a MYC amplification. So I don't have a fancy picture for this, but the TET2 gene is a methylation regulator. So potentially these 2 changes in the single nucleotide variant route could lead to oncogenesis, although maybe we're grasping at straws with that one. In terms of the MRE11 mutation, what was interesting was that this mutation was essentially the same as the one identified in the university patients, and these are noted to be distinct patients. However, some of the conflicting ideas here is that, is this change too common to be present in such a rare tumor, or is it too rare to be a coincidence, which is something that we have to come to terms with and try to figure out what the answer to it is too. In terms of our other VA patient, noted 8 concordant mutations, including KDR, the APC gene, which has a likely pathogenic change, NPM1, CDKN2A, ERB3, TP53, and JAK3. JAK3 was noted to be likely benign in this case. In terms of the copy number variants, we found that the CCND3 was amplified, and additionally noted that there were duplications in the EGFR, PIK3CA, and Richter, which are involved in the same pathway, which could suggest some changes involved in cell cycle progression and cell growth as well. A MYC-N duplication was also identified, but this was only seen in one of 2 samples, which raises the question as to whether this patient acquired it over time, or whether there's simply an issue in quality, or whether it was present but we didn't call it in one sample because our level of quality filters felt it was insufficient to call it. So this is a better picture than me explaining it, but as you can see, the cell signaling pathways involves a number of different proteins and molecules, and there were noted to be changes specifically within this patient in the EGFR, Richter, PIK3CA, and TSC2 pathways, which could potentially alter signal transduction and alter proliferation of the neoplasm. So this is very preliminary results in terms of the question of what's the cell of origin. The negative OCT4 staining and lack of changes in copy numbers in chromosome 12p suggests a non-germ cell origin, but in terms of our findings limited to a number of genes that were present in the panel, as well as a small number of patients, doesn't let us definitively make any statements, but merely lean more likely towards that somatic origin. Some of the commonalities of the copy number variants, changes in the proliferation pathways, as well as loss of function in genes involved in DNA repair, suggest some potential related changes, but these would have to be looked at a little further. Additionally, some of the changes in the single nucleotide variants also involved in DNA repair, as well as proliferation, could be of clinical interest. However, the one takeaway that we have of this so far is that there's no pathognomonic, no changes that we can see that without it we wouldn't have this neoplasm. So so far there doesn't seem to be anything that we can really hang our hat on in terms of a specific change or feature for this diagnosis. So some of the continuing work that needs to be done, additional look at some of the things that were called and some of the things that were called in one sample but not the other, and looking at why it is potentially present in one but not the other, requires a further literature review of some of the variants of unknown significance and some of the likely pathogenic changes, and whether these are actually real or if they're potentially just noise. And in conclusion, this is a very rare neoplasm with limited results. So the significance of a study that doesn't exactly highlight major changes could still be of benefit in terms of progressing the body of knowledge involved in this entity. So that is my talk for today. I am welcome to take any comments. I do have a flight to catch, so I can do one or two, but thank you for your time.
Question?
Yes.
So the panel you use, that's a hotspot panel, or it's covering like all the genes, all the so specific?
There's that one picture where it covers that the full genes within that specific.
Kevin goes back to that. Everything in the green circle is sequenced at a DNA level, and then within the purple circle, those are the ones that have RNA sequencing for fusions, exon skipping events, and then the blue are the ones where they QC the coverage on the DNA level well enough that they can call out to patients and deletions offices. But everything else, everything's a full gene capture.
All right. Thank you.
All right. Thank you.